Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 202. We have an excellent teaching case today, a genuine 111 Medina left main trifurcating lesion. You're going to learn many lessons, including the optimal use of imaging to guide you with these cases. With this introduction, let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are all ready to teach you. Samin, Anu, good morning.
Good
Oh,
morning.
good morning, and we are right on time. And of course, keep trying to show the latest and more complex case. This is one of them, which is trifurcation. Always question comes what to do in the cases, and this is the case which we are going to share very quickly. And welcome all our CCC live case viewers, which is numbers keep increasing now. It's average 33,000, and we have fellows Neil Patel and Monica, and our nurses same, Raika and Will, and CVT Asif Habib, and imaging is Kiski. With that note, our target audience overview, learning objectives remain the same. Faculty disclosure, no, nothing has changed. And this is the case episode 202. In February, we celebrated 200th case, and this is the 202. 87-year-old patient presented, had a known moderate CAD for last 12 years, and now had an increased angina and positive CTA. And FFR CT was positive, and risk factors wise nicely controlled, as you can see on the left side, all the risk factors, and including BMI, normal creatinine. And patient has, as I mentioned, stable angina for 12 years, normal ejection fraction, and now see the good medical therapy this patient has, and has now Anu is going to show what the CAD showed, which was that trifurcation. And remember, trifurcation will be 0000 or 1111. So in this particular case is 1110. And let's see this again. Yeah, the circ looks okay. It is the
Absolutely.
ramus, LAD, distal left main, and so it will be a 1110.
Yeah.
Anu, say it
No, I
angiogram. Yeah.
think circ is involved.
Okay.
Ostial circ too. One, look at the angulated circumflex. Ramus, I think, will be okay. It's
Ah,
the circ that is significantly diseased, and more important, that's where I took a couple of pictures to see the distal circ,
yeah.
where there are two LPLs. It's a dominant circumflex, RCA is small,
Yeah.
and definitely a lot of calcium with distal left main
Yeah.
involvement.
No, I'm sorry. Let me correct myself. It was because remember the fourth vessel is the smallest vessel, that's ramus. So it was 1110.
Mm.
Ramus is no disease. It was the circ, distal left main, ostial LAD.
Yeah, so
Yeah.
111,
Zero.
and
So
then
ramus was no disease. That's why we call it 1110.
yeah.
And then there is additional disease in the circumflex downstream, which is 90-95%, which we had to take care before we do anything to the left main.
I
Yeah.
took few views and we'll decide on that. And then look at the diag, right? I
Yeah.
think we are okay with the diagonal if
Yes.
when we go further, EF this non-dominant. So this is where you see that
Yeah.
this the distal circumflex wiring
Yep.
could be
Samin,
challenging.
active audience questions already shooting up. Anu, I
Yeah.
think you'll find it intriguing too. First of all, the observation is why no impella? That probably is because of the good EF.
Yes.
No, we'll talk on
Yeah.
that a little
Yeah.
bit, and then
Yeah.
we'll
Yeah.
go here
Yeah.
cranial view. You have D1, D2, not deceased, but then most of the disease, everything is in calcific LAD.
That's it. Yep. And then the question come back for the impala issue, and knowing that now, although it could be ideal case because of complex anatomy, but EF normal, and knowing the recent data of the BCIS3, which we are going to share, we are kind of a little more selective, because remember all these things then become at a high level in terms of scrutiny, and we want to use it appropriately. But yes, if we start having any trouble, we'll put it right away. So this patient actually, go inside, yeah. Patient taken out, we referred him for CABG, but because of the age and because so complexity, we rightly with a syntax score of 35, patient declined due to age, and that's very common. More than 80 years of
Fine,
age, and this patient continues to have angina despite maximum medical therapy and now planned for high-risk PCI of this left main trifurcation using RotaTripsy and MiniCrush technique. So appropriateness point of view, as you can see here, yes, it will be rarely appropriate, the cases with the left main, but it is basically because of the discussion. May be appropriate, and so after heart team discussion, these cases becomes, in my opinion, appropriate. So this is where now Anu tell us the strategy, and we are ready to rock and roll.
Okay, so in this complex circumflex, right? Now we definitely are going to take care of the distal circ first.
Yeah.
So there's two ways. We may say leave the distal circ, let's just focus on the main area, which is left main LAD diagonal, and we can probably do the distal circ later, but we'll try. If the wiring goes easy, we'll do the distal circ, stand there, and then focus on the left main.
Yeah.
The
Get a
question is,
2.512 balloon.
yeah, how would we wire it? So I definitely have a fielder. Would I go just with fielder with 2O balloon, or we go with
2.5.
fine cross? Selecting fine cross with fielder. I still think the way with the calcium and way the circumflex ostium is deceased may not be easy, but we can try. Give me the fine cross.
That was my thought also. The origin of the circumflex is very tortuous and angulated at that origin, and
we'll put a
excellent.
timer on. We'll try. If it's difficult, we'll just focus on the main. But then going back to the main vessel, are we? If we have to go back and decide that are we going to do atherectomy or we right?
I mean, LAD is very calcified.
So we can, if the circumflex wiring is not that easy, we will leave that. We will go to LAD. We will go rota floppy wire, and I think without imaging, using our eyes, EYE, we will go 175 bar. What's the?
Okay, so that's appropriate. So clearly now, question of the impeller, I think we'll never know what to do with a normal ejection fraction and complex CAD, because none of the trial will answer that question. Even current impeller, the MCS trials have EF of 50%, has gone up to 50, but the trial which we are waiting is the Protect 4. Their EF was 30%. Originally started with 40, then we became 30. So this the low near normal ejection fraction and complex CAD, I don't think we'll have any trial ongoing, and we'll have answer to that. Yeah.
Let's have a balloon pump standby.
Yeah.
Very large left main
Balloon
and
pump, yeah.
proximal
Balloon
LAD.
pump.
Yeah.
I'm sure that guided your decision for the 1.75 bar. I normally would have thought that you would have stayed with the 1.5, but
Yeah, no, I think the LAD will be okay. So this case, LAD is nice, and it's not a subtotal vessel. We know eccentric, about 80% distal left main. Actually, main is more troublesome than even the LAD. I mean, the tightness by point of view, it's more disease in the main than in the LAD. Okay, now you have to make a different curve.
much sharper curve.
And otherwise, we have those our
run through wire. Maybe we need the run through.
Give the run through.
I
But
have
otherwise,
it
we
here.
can always use that super cross 90 or 120 can always be used. Yeah. So this goes
if
into
we are thinking that
OM.
we should just focus on LAD.
Yeah.
If we think that's what we need. You see that?
No. We have to open the circumflex.
No, not now. We will focus on a rota of the left main LAD and then go to circumflex.
Yeah, that's okay. That's reasonable. Get a 1.7 ready.
I think let's do that.
Yeah.
This is not.
Nothing wrong in that. So this way you'll increase the lumen, and we know with the rota side branch closure occurs very rarely, and is not the issue. A lot of people want to use even some device to protect for the side branch. They are using yeah, good. This is very tortuous LED. Good. Let's go there. But I can say that we have never needed any device to protect the side branch. If need to be, you can do a small balloon. But using a guideline, a guideliner or any other device, particularly covering the main vessel, because you cannot do the rota with the side branch, so you can put that in the side branch and do rota of the main, but will require 8 French guide, which are very difficult to difficult, I mean, vascular complication may go up, but more importantly, many labs don't have the 8 French guide, and definitely don't have the 9 French. Even we don't have any 9 French guide. Remember, a few years ago, we needed 2.38 bar for the osteal RCA, and that we had to get that guide came from California, from Medtronic. Medtronic is the only one who made 9 French guide.
Anu,
other
that was
company
the
made.
fine cross you had used.
Yeah. We change it
So,
to rotawire
so
now.
putting in a fine cross, crossing with the fielder, replacing with the rota, all in 18 seconds.
Yeah.
Unbelievable. Anu, there is a question for you. This is by Dr. Mara Mohammed. Why Dr. Kinney prefer fielder in many cases? Is it preferred here because of the tortuous circumflex?
Yeah, so question is, I also, if you see there, when we went into the circumflex, we went into the ramus. Let me go back. When you wanted to make that turn in the circ, you see the way it is, the circ takes off and the angulation. So usually polymer jacketed hydrophilic wire are better to make that turn. So when we use a fielder, it went into ramus. Now you need almost 180-degree bend there. I called for actually run through, because run through, you see that it's hydrophilic coating only, but there's no polymer jacket at the tip. So we could have used that to make that turn into the circumflex. So that is one. If we still had issue, I would have called for Miracle 3.
And I know that a lot of people.
One day, I think we should give lectures on the wires. I mean, we have shown various wires multiple times, but why we use which wire and which vertical. It's not that we use too many wires. Maybe as long as for CTO, we have about 6-7 wires that we consistently use. And for our regular cases, it's either fielder, run through majority of the cases, rarely whisper. Sometimes we call for these miracles and fighter.
And I know that a lot of people use the fielder FC and all, but the problem is they're a little more flexible, but then they have no body support.
Yeah.
So that's why we don't use fielder varieties. Usually the fielder, regular fielder is our workhorse wire after the run through.
Now, Andrew, if you are there, can you just show the fielder FC and regular fielder slides in the side?
I mean, question for you. Could a cutting balloon have been used here?
In terms of, yeah, I mean, the cutting balloon or IVL. So other thing you can say, look at the calcium, but a cutting balloon alone will not do in the heavy calcium, but at the same time we knew that cutting balloon does do well in the more calcific lesion versus non-calcific lesion, as has been shown by the Koff's trial. And so remove this project away. Let's go.
Okay. Going back to your question, if could you have done cutting balloon? Yes, you could try high pressure balloon, cutting balloon, but then if your calcium modification is not appropriate, then you have to go to the next. The only one that will be available will be IVL at that time. And in this patient, which is left dominant, disease in the circumflex, and you're going to do an IVL, you should definitely be careful, because when you are living for that time, you can develop ischemia and EKG changes, which we have seen when we are doing left main.
Yep. And it's not 10 seconds only, as you know. It is about 13, 14 seconds, because you have 10-second inflation, the cycles, and then you have to go 2 atmosphere higher and then deflate. So all the process takes 14 to 15 minutes, and some cases may go into a hypotension at that time. Now, there is clearly the new generation shock wave. Instead of 10 seconds, they're delivering all the shock in 5 seconds. So that's the new field which will be going to happen and continue to improve. That how can you have, and I'm sure soon they will have maybe you pull back. I think we're too much touching.
No, it's okay.
Yeah. Okay, good. Yeah, just start here.
Okay.
So little away from the lesion, and then 3 steps which have been done at Y connector, entire device, and the rota at Dynaglide.
145, 45, 5 seconds, 50, 10 seconds.
Pull back. Okay.
Absolute.
No.
Yeah.
See, despite 175 bar, you see that
How easily
slow
it went.
pecking motion. Yeah.
5 seconds, 150, 50, 10 seconds,
So this is the left main, right?
150, 15 seconds, 150.
I'll go to the second lesion. Okay, now second lesion here.
Other view, yeah.
Okay.
At the level of septum.
Yeah.
Yeah, keep going.
Go right.
Yeah, yeah, that's fine.
What you want to do?
No, I
Don't
just
you-
wanted to show that where we are. Yeah, just it. I wanted to show that.
There could be a lot of wire bias here.
So you keep changing the wire position to avoid the wire bias.
Other thing is, even if you do not make the complete turn, we are okay. I think majority of the lesion has been taken care.
Yeah. Yeah, but there is a calcium there in the there. It's a one side only.
Yeah,
It's a
I
moderate.
think we can leave it.
Proximal was a severe. But let's
Let's
try
come
one
back.
more. Otherwise, it come out.
150, 150, 5 seconds.
I think come out. Going.
150, 10 seconds, 150, 150, 15 seconds.
So
Okay, ready?
for our viewers, they should observe
Get the run through.
how this maturity and decades of experience teaches you that look, you know, the proximal is done. Let's not push too far.
That is correct. Yeah.
Sameen,
back the
already
wire.
questions
Wire.
coming. Some very interesting one. Dr. Syed is asking, which I'm sure is going to be the next series of questions, the strategy for stenting. And would you consider the left main, I'm quoting him, would you consider the left circumflex as the main vessel given its size and difficult angle for recrossing? Excellent question.
Absolutely. Yeah. And remember, the Medina requires not the area subtended, the size. So Medina point of view, if you see the circ is bigger, so it's a one is the circumflex. Yes, that's the basically main Medina classification. Let's run through. So circ is yes bigger vessel than the LAD, from the Medina point of view. So yeah, so our goal will be you protect both of them, and that is what our mini crush technique will be. Whether you want to do a DK crush, fine, but there's a lot of calcium at the ostial circ also. See that? The chunk of calcium. So there, I would say probably go with the cutting balloon once we cross.
Now, let me tell you one thing.
Yeah.
Let's wire it.
Yeah.
And see how it behaves.
Yeah.
Nothing wrong that we do IVUS, and I think I want to do IVL there, the way it is.
Yeah. So only question is the circ will have a little difficulty in terms of IVUS, but yeah, we'll try.
We'll try.
Uh,
We'll try.
Yeah. So right now we are going to go back into the LAD, and then we try the circumflex again.
Go back to
with
the caudal. Let me
yeah.
see if I can do. Circ
No,
with the
with this
circ
wire?
with the run
run
through.
through wire. Okay.
As it is, I think in several bifurcation, trifurcation cases, pot is critical. I think in this case, it will be of extreme importance to get it exactly right, perfectly positioned so that it is not too distal either.
Yes. And that is what the importance also when we are talking about pot, make sure enough the stent length in the main vessel, because otherwise will be an issue. Little die.
Probably needs a
Ramus
much more
again.
sharper angle, no?
Yeah.
You made the new curve in this, right?
Yes.
Okay.
So Anu, my
we'll
choice here.
Yeah.
Okay.
Good. Went
Nice.
it.
Exceptional
So
job.
let's do the balloon now.
Well, you see, I changed the wire.
Yeah.
This is a run through.
Just exceptional skills.
Yeah. Let's do the balloon now with
Of the distal.
Yes. We have the
No,
2.5
the distal.
balloon.
I
Yeah.
need a balloon.
Yeah,
for
2.5 balloon we have. Bring it.
Okay.
Yeah.
Because now what
Such
happened
a large
is
vessel distally. Yeah.
I made that curve, but the curve is, you see that is not the right curve to
Go
cross
through the
the
lesion.
distal circ. Yeah.
Yeah.
So
It's
now you
good
need a
for the
balloon.
circ, not for the distal lesion.
Yes. So,
So
what
Sameen,
we'll do is change it.
Keeping
With the
with the flavor
Wire.
of the year, Dr. Ravi Kiran is asking, could we also be dealing with the calcified nodule at the left circumflex ostium?
Could be.
Very likely. Yeah.
We have a trial going on. Wow. Okay. That's called nodule shock. And
Mm,
you won't believe, yesterday we had 3 cases, all 3 cases on imaging, we found nodules.
Hmm.
No,
Yeah.
die.
Good.
I
That's good.
think
No,
Good job.
I
nodules were
don't think so.
always there.
Yeah.
We are
This is
just
the branch before. Yeah.
Being
good, fine.
aware,
Yeah.
yeah,
got,
more
getting
aware.
aware now.
Yeah.
1 second, let me go to
That's
the.
any one of them is fine.
Samin, in the meantime, I'm not able to pronounce the exact name looking at the email address, but welcoming our viewers from Canberra, Australia.
Wow.
Oh.
Beautiful.
What a
Our
joy to
numbers-
have you.
Yeah.
Please
Okay.
keep providing any questions you have. We'll do my best. And also, if you can spell your name correct, I'd like to identify you appropriately.
It's a 2.512 non-compliant balloon.
You understand? I want to go into the distal SS. This
One
is
second.
going into, it is going to LPL and it's a dominant circumflex.
Mhm.
So
We've
when
had
you sent it, no matter what, we don't want
Yeah.
to give, jail that.
Okay, go to this view exactly then.
Go.
This is the view of 38 to 18. 38.
You know, I can tell you, I don't remember the patient's history if he was having a severe angina, but if that was, the circumflex mid lesion is the
Right. Yeah.
culprit.
definitely.
Such a
Yeah.
large dominant vessel,
Yeah.
we'll be surprised how big
Yeah.
the vessel becomes. There you
Yeah,
go.
distal,
Yeah.
distal circulation.
Yeah.
Yeah,
This is
Yeah.
the
go.
one. Okay. The balloon came back.
Uh-uh.
You have to go slow. So many times when you put a balloon on the spring tip of the guide wire, it
Okay,
may
go.
just comes back, but we go slow. Then you go a little slow.
Okay, down.
I think we are okay.
Okay, down. I want to make sure our wire is in the right branch.
What you do is
Samin,
pull back. Yeah. Let's take
Okay.
both of you, I think, have deserved this. I didn't say it, but Dr. Mahmood El Rais has
Yeah.
called
Wow.
you both something. Hello, state-of-the-art operators. Excellent. Appropriately described, Dr. El Rais. Thank you.
You want to open just the distal ostial circle a little bit before your IVUS?
Mm-mm. No, I think IVUS will go.
Okay.
Even the stent will go.
That
Right?
we
You did it?
already. Yeah. Yeah.
No. Give dye, don't
No.
unnecessary dilate everywhere. Okay, good. So you're going to put what? 3O?
3O.
Go up.
3O.
Patient, actually, I can tell you, he did lot of, he had a non-obstructive disease many years ago.
Yep.
Yeah. Then nowhere to be seen. And then he
3O
did a
12
he did
or
a lot
15.
of Mr. Google reviews,
Yeah.
check. And very clear. He said, if I want PCI done, I think he has seen some of our live cases also.
Take it out. Done.
Right? Right? He has seen, right?
Very intelligent patient.
Yeah. No, yeah, not even that. He's requesting Zion stent.
Yeah.
He said he wanted MiniCrush. Zion stent is like, come with everything.
As long as it didn't say DCB. Yeah. Yeah. As long as it didn't say DCB. Yeah. Yep.
That's the future. Patients will come with all.
Because nowadays, nowadays they
will.
come with a chat GPT.
Yeah, with the use
Where
this.
do I go? I actually every month I would say at least I get 5-7 patients on the chat GPT that who has the highest volume of intervention comes out Shamin Sharma. I haven't checked it myself, but a lot of people have said that.
It is correct.
No, I don't want to say it. There are a lot of people who don't even do procedures.
No, ChatGPT. I'm talking about
ChatGPT is saying they are the top interventionalists.
That's a different thing. Highest
so
volume.
we don't want.
Yeah.
They're just going with publications right now. Okay. Okay.
Yes.
Excellent. No surprise, there was some challenge there.
Yeah.
Mm-hmm.
Okay.
I didn't want to, dilate because we want to IVUS and prove that
Good.
there is,
Go.
Okay.
Okay, get the IVUS ready. We have the IVUS ready,
Yep,
open,
we're
right?
fully ready.
Okay,
12,
good.
14.
Okay, down.
Go up again.
Key is very particular that if we are going to do IVUS guided procedure and PCI, we need to do we got to do maybe in between and post. So if there is no that's why I don't want to dilate it and not have the right imaging analysis.
Oh, wow.
Okay, go. You have the slide that we need to do pre-assessment, assessment in between after the device.
slow flow.
Yeah,
Hmm.
which
Okay.
we knew. That was probably his chest pain vessel.
Thrombotic from there. Okay, get Mr. Verapamil. Yeah.
Now I can go to this branch.
Yeah.
Okay.
Good.
You wanted to go to that branch for more support?
Yeah, because it's in a small vessel,
Yeah,
and
yeah.
now when I'm doing
Better angulation,
multiple, wire exchange and all that. Now only question is LED is still the rota wire.
Just finish the IVUS and then we change.
Okay.
But let's have make sure the flow is a little better before we
Okay.
go in. Yeah, yeah.
So what is
I
your
gave
predictions?
Verapamil.
I mean, the proximal osteal circumflex is all angulation or lesion?
No, there is
No,
a
the
lesion and there is a
lesion and the
lot of
calcium.
calcium. Yeah.
Calcification.
Yeah,
But
yeah,
not
yeah.
a severe, but moderate calcium. Let's see.
Have a 3-5 and a 4
Yeah.
IVL ready.
Maintained. So good. 3.5. Won't go. Big one will not go because we're not dilated. Go.
Yeah, I mean, we will tell you.
No, but do we get the new Aero
Yeah,
IVL
yeah.
now?
Everybody is aero.
Okay.
But I can tell you during the live cases we did last time, one was to India, one was here to Arch, and was left main.
Yeah.
Both the time we were struggling to get it across. Okay, can you see it?
Yeah, this is a left main bifurcation.
No.
No, I know, but it's there. Otherwise, I have to
cross
pre-dilate.
now.
Okay,
Cross.
good. Okay, start.
Okay, start feedback. So normal proximal circ,
With no
big
plaque.
vessel.
Very good.
Yeah,
At that level.
come to the osteum. Yeah, eccentric calcium. You stop it.
Maybe just cutting balloon then.
Yeah. The arc is not that wide. So this is a proximal left main, eccentric calcium. Now come to the distal left main. This is, yeah, the surface of the, looks like it was calcified nodule protruding, but the surface is shaved now.
Yeah, with the rota.
Yes. Then this come to the bifurcation. This is osteal.
Huh.
Actually, not that tight. The osteal circ, yeah, there's some eccentric calcium, but not much calcium actually.
Wow.
All adventitial. But hold on, where is that?
So this is a distal left main bifurcation.
So you are telling us osteal circ is okay?
Because now I see the first branch should be the LED. Then the second branch, this is the remus. After that, so this is the osteal, circ. After the remus, but this cross section is actually
7.6.
One second, but sometimes it's not correct.
Actually, you know what? This makes case very simple now.
Stent across?
Yeah. I mean, clearly that osteal, so you remember even that happened in the FAME 1 trial where they recalibrated second 2 vessel, 3 vessel disease, and many of them 3 vessel became 1 vessel, and about 6% became 0 vessel based on the FFR. But this is imaging, but that was based on the FFR. So one is the anatomical CAD, second is the physiological CAD, and third you can say imaging CAD. Here looks like circ looks very good. I don't think we need to do anything here.
That's what I think.
Now question is, do you want to just then put a wire in the LED and really see the how left main and LED is?
Yeah, get
Combination.
me
Yeah. Let's get the fielder wire again.
No, I think fielder is gone. Bye.
Get a new one.
I'll leave the rim. You want to put a fielder, then we stent across.
Yeah, that's fine.
Now,
Now,
I mean, the physician from Canberra is Arun Nagarajan, and
Nagarajan, yes.
Anu, he's called you as the operator who doesn't need a torquer.
No, Nagarajan, he has been with us. He has some nice comments. So later on, when Dr. Sharma is going to show some slides and talk about, then I will talk about the torquer, okay, at that time, at the right moment. So Samir, you were right, that maybe it was just the way the circ was taking off.
I something told me it may
not
be.
And then see that calcium nodule or calcium, whatever is no nodule, but there is a calcium only barely 70 degrees, not even 90 degrees.
Yeah. No, nodule is there in the left main.
To me, the entire teaching purpose here is that the role of imaging here, it changed the whole case.
Yeah, that's correct.
But see, our decision of LAD, we knew you had to do rotational atherectomy before imaging. But with circ, we said, okay, let's, if you want, image the circ. If you had not imaged, we would be doing, you know, bifurcation intervention of the left main.
So now we're putting a fielder wire into the LED. So that then take the our rota wire out at that time.
Don't pull the thing back. So this. Once.
You can run through also here.
Yeah. Okay. Run through. Yeah. It's going into the ramus. The question was.
We want to shape it a little more.
Run through is a better wire.
Okay.
Get another run through. Keep it if you need it. Clean.
Yep.
So we'll use a run through.
And he showed the differences in the FC and regular fielder, that slide. We had the.
Did you see that? Can we put that slide back up again? I don't know if they can see it on that small screen.
Yeah, we were able to see it, but it was on the small screen. Yeah. Philip will help you there. And Philip, excellent job. I mean, if you take a look here,
right
we
there.
are seeing IVUS, hemodynamics.
Fielder FC, fielder XT, fielder XTA, R, all those. So biggest problem is people give us fielder FC very commonly, but that has a hydrophilic, but the body is very weak. And we had trouble with that. Anyway, let's go back to the our fluoro, the crossing of this LED.
Anu, really, this is, I want to congratulate you and Andrew. This is not easy. You know, magically he's there and he's able to pull up the slides, ready to go. Excellent job. Excellent job.
Yeah.
Enhances the teaching so much. Okay. Once again, torque free.
We can remove this wire.
Came out. Okay. Okay, get us imaging.
Rota wire has been removed, and now we are going to imaging in the LED. Throw away the rota wire. Pull back one of you.
I know it would be difficult, but would it be impossible to image over a rota wire?
No, we can. I do it.
Yeah, can be done, but
not easy.
Yeah,
and not recommended, I think.
Yeah, because if anything happens, it lift the plaque, then putting additional devices will be a little difficult. Now, you can do on the wiper wire, which is still okay.
No, rota wire we have done multiple times.
All right, Keski, we are going into the LED now.
1 second. Can you show the IVUS on the screen? Check.
Okay, go.
Good.
Yeah, check the image. Yeah, start pullback. This is the mid part of the LED. Here's no plaque. Now some calcium plaque start. Yeah, flux LED has a lot of calcium.
Okay, good. I think this.
Then this is the left main. Stop it. Yeah.
Yeah.
Okay.
So LED was really full consenting calcium.
Yes.
Yeah, right there.
Yes.
And we have some cuts.
Yeah,
So
I see some like fracture.
You see that? Yeah. I think we can just balloon and stent across.
I don't think we need IVL in this one. No.
Nothing.
Well, should do cutting balloon.
No. Go back to where the tightest area is.
But
right
have
there.
we done some cuts? That's the question.
Yeah,
right there.
Looks, surface is shaved and the leaf ablation. This means the surface of the calcium is shaved. That's why it goes smooth.
At 7 o'clock, go back 7 o'clock. What do you see?
So here, this is also leaf ablation.
Yeah.
Yeah, this like artificial arc is shaved by the 175.
3.520 balloon.
So it is telling us we have done the rotational atherectomy has done calcium modification. We'll do high pressure balloon and stent.
3 or 20.
Risky?
Yep.
Agree?
Yeah, I agree. And other point is the huge size gap of the size LED and the left main. The start of the pullback is like less than 3.5 vessel.
Okay. And left main is 5.0?
4.5 vessel with some eccentric calcium plaque. But
okay, what we'll do is we'll take a 4.0 and then proximally optimize the left main. 4.0 low pressure.
And 4.5. No, left main is what size?
More than
4.5,
4.5 vessel.
Yeah,
but
okay.
we'll take a
The
follow stand.
mid LED is
Yeah.
not follow vessel.
We'll go low pressure.
That's low pressure, yeah. Or what if taking a 3.5 28 and proximally dilate with the 4. Or 4.0
Yeah,
high
that's
pressure? No.
Samin, maybe right time for you to start your presentation.
Let's
Okay,
put this.
we can do that.
Yeah.
If people want that, that's fine with me.
Good. Okay.
Because there's nothing weird. Majority of the decision has been made.
So just
Yeah.
dilatation balloon. And okay, let's continue our slides.
28, we are taking a 28.
Yep.
Okay.
3.5 28, right?
No, we are doing a 4.0, no?
4.0. Okay. 4.0 28. All right. So our latest issues in coronary interventions.
No,
Uh,
no, 3.5.
Key imaging trials, because there was such a controversy this time. 2 positive, 2 negative
go.
imaging trials. IVUS chip and DK crush from ACC, Renovate complex PCI. I'm sorry, IVUS and optimal, which were negative, DK crush and Renovate
Done.
complex PCI positive.
4.0
And then I'll
28.
talk about the high risk chip BCIS 3 trial, another negative trial. So
Okay.
basically,
Go.
the imaging point of view, as we know, that PCI optimization targets on intravascular imaging, edge dissection, stand under expansion, malposition,
Good.
all those are shown that you should have a less plaque at the corner, less than 50% plaque burden. That means otherwise you are not covered the lesion. Then your dissection, there should be less than 2, or some people say 3 millimeter in length, as long as it does not involve the media. Then malopposition, which is less than 0.4 millimeter, and in terms of distance, and 1 millimeter
right?
in length. And then, of
33.
course, the MSA, which is one of the
35.
most important, that should be more than 5.5 on IVUS and 4.5 on
35,
OCT.
33.
Now, many times your vessel is only 2.5 millimeter. You cannot get 5.5. So they basically say it has to be for optimal
Okay,
stent
33.5.
expansion
Low
is
pressure.
your average reference lumen more than 80%, or if you want to go to the distal, should be more than 90%. And for the left main, 8, 7, then 6 for LED and 5 for circ. So that's the combination, 8, 7, 6, 5. Now this is one. Second, as we spoken, pre, post, and final. Pre-intervention assessment, which we did, then confirm during the procedure, which is post, and then the final, which is, to me, a lot of people have a different opinion. What the contributing factor for which one? I can tell you from my point of view, I feel that your pre-15, post is very little, and final, ultimate is the final. People may disagree, but that is what. Now, point is, I was used, just to say, in America 4 years ago, in 2022, 2022, used to be 5 to 8%. Now, in 2025, we don't have the data of 26. End of 25 became 28%. Imaging, not IVUS only, imaging, intracoronary imaging or intravascular imaging. Now, where we'll go, we'll figure out. Just to emphasize once again, highest use of intravascular imaging is in Japan. There are 90+%, all the interventions are done using intravascular imaging. Now, then second point is that mechanistic pathway linking IV imaging guided PCI to early and long-term clinical benefit. Intravascular imaging guided, we learned it, accurate sizing, post-PCI optimization, then early procedural outcome. You have a better, less stent thrombosis, geographical miss is not there, dissection is not there, under expansion not there, and then long-term clinical outcome, which is the ISR, neoatherosclerosis, late stent thrombosis, and other MACE point. So this is very nicely depicted mechanistic importance of various kinds of when we do the imaging and benefit in the long term. So with that note, with that background, I want to show you 2 and 2 trials. First was the IVUS chip, complex high risk indicated procedure done in Europe, and basically they have the complex cases, which we basically define, bifurcation, severe calcium, left main, CTO, and then they actually had a very nice optimization criteria. Your MSA has to be more than 5.5, which we just talk about it, and the distal vessel more than 90%, 5 millimeter or 90%, plaque burden at the edge less than 50%, no dissection, more than 3 millimeter in length. Then optimize them. If you have MSA low, go high pressure. If you have a plaque burden, put another stent. And if you have dissection more than 3 millimeter, put another stent, and then get 8, 7, 6, 5, as I mentioned. And of course, the outcomes were classical target vessel failure in about 2,000 patients. So large trial, and basically showed that by using other factors were kind of okay, I mean similar, little more atherectomy used in the IVUS guided PCI, and the total procedure duration was much higher. Almost you can see there 22 minutes, kind of 22 minutes higher. All the procedural complications were identical, about 10%. And what is the end result? So first thing is IVUS guided PCI, the IVUS optimization criteria were obtained in 48% of cases. They met. So, and this is nothing new for this trial. Most of the trial have shown half and half, that about no matter how good you do, but optimization occurs in only half of the cases because of various factors. And I'll come back to that a little later. But the primary endpoint, height of the blue bar versus the angio guided PCI total stroke. Everybody was, until now, the trials were intravascular imaging, plus, and all of a sudden here, it's other way around, neutral, or rather on the other side. Only difference was lower stent thrombosis. So this trial, the first one after a long time, to show that IVUS guided imaging was not beneficial compared to angio guided PCI, and except the stent thrombosis, which was significant. So this basically was. Second trial was optimal trial for the left main, which were waiting for quite a bit. As you know, all these are in the part of the guidelines. Whatever the criteria of the IVUS, the chip was, the guideline, the class 1 indication. Same thing left main. And their left main basically was that do you need imaging, or you can just do the without, and both these trials require use IVUS, not the OCT, but the IVUS. And basically protocol was the same. This is a little smaller trial, 800 patients of the left main. Only difference was number of stents were a little more with the IVUS guided, but other, and then of course procedure duration was much higher, and there is no peri-procedural complications, were no difference. Basically, again, another trial. They did not say in this trial that how many percentage were the optimal IVUS. So that's the only difference. But IVUS guided versus angio guided, again, you see the height of the blue bar slightly higher than the red bar, but no significant. Stent thrombosis actually a little higher, 2 versus 0.75. So basically this trial, left main, showed that imaging did not help. Rather, it numerically higher stent thrombosis. But more important, look at the stroke, 3 versus 1. Now they say, how can that be? Stroke occurred almost 1.5 years later. The reason is why stroke will be higher with the imaging. They speculated that the catheter remained too much because the higher procedure duration, multiple passage of the imaging catheter caused the stroke. But this is the first trial we showed the stroke higher. No other imaging trial showed stroke higher, and so. And all the other endpoints are shown in this 3.9 year. Overall was 2.9 year mean, but the trial was 4 year data, which we have seen here. So sum it up, 2.9 year follow-up of the primary endpoint in these patients which are 70, age about syntax of 30, and showed basically PCI guided in 401 and angio guided 30.9. And now one of the reason you have such a high number of the event rate is because they counted other factors. Basically, the many other factors were counted in this particular. So any myocardial infarction, any injury, and so on and so forth. So this is where basically the optimal trial again became negative. Now, so we have the two nice editorial. I was a zigzag path to success by Castrati, and it basically showed that in complex cases that you do intravascular imaging is yes, stent optimization, but do you really need it? So question was that if you have a stent optimization, you can do any other way, probably may not need it in every case. They also said that anytime you worry about these long lesions and moderate plaque burden, maybe you could use a drug-coated balloon. Then by Frederick Welt, that IVUS is the left main, is it necessary? And they basically goes through all these points in this, showing those both were negative trials. That should you be using IVUS is a large vessel, although it's a contrary to the recommendation at this time. But problem is that you can do good intervention, good imaging based on the angiography also, and the IVUS did not help. Now, these are the two negative. Now let's come to the two positive. In the ACC, DK crush 8. Remember DK crush 5, which was the DK crush versus conventional, and then DK crush 8 was all DK crush, but imaging that you do the IVUS guided versus the angio guided. So DK crush technique and primary endpoint and all those things were shown same way. Double kissing crush, distal left main bifurcation in these cases, and evaluation of the IVUS was done. Baseline after wiring, the wire is not correct, then they rewired it. Second wiring. So a lot of very methodical imaging were done in this trial. I can tell you there is so much description of how your procedure should be done. Is this the DK crush technique and DK crush 8 here? So basically, I was guided DK crush. All of a sudden, now you see benefit of the height of the blue bar became significantly lower than the red bar, and of course, the stent thrombosis numerically lower, 0.4 versus 1.1. So clearly, the DK crush 8 was totally different than what were the first two trials, IVUS chip and optimal trial showed. And these are the landmark analysis in these particular cases. Not only 30 days, even after 30 days, TVF and myocardial infarction and TVR. So basically, what did it show? The reduction of ischemic event up to 1 year, 6.1% in the imaging, 14.7% in the angiographic guidance, and totally different. And this actually compare DK crush 8 like October trial, which was the OCT use, and basically shows, as you can see, TVF in the guidance, imaging guidance versus angiographic guidance. As you can see, the difference was 6.14.7 in the October trial using OCT in bifurcation, 10 versus 14.1, and it basically was driven by the lower TLR. So key is biggest imaging, biggest benefit of imaging is mediated through the TLR. Then the another trial, which is from South Korea, Renovate, has been done. We presented that with a 2-year follow-up in the past, 2.1 years they showed. Now we have 5-year outcome of this randomized trial. As you can see here, again, 2,000 plus patients with the primary and secondary outcome. And you see here, target vessel failure, 14.9. With the angiography, 10.5 with the imaging, and target vessel failure without MI is 11.3 versus 8.1. Clearly benefit of, again, imaging compared to angio guided. Again, the blue bar we can lower, including lower stent thrombosis and so. So clearly, two trials were negative, these two trials were positive, and more important was the benefit after 2 years, because 2 years is the one presented earlier. Now after 2 years, really benefit was 2, but you have about 1+% still benefit on the primary endpoint after 2 years. So this basically, there's a very important question this trial answered. What if, is there a difference in the optimal imaging criteria patient versus those who did not achieve? So as you can see there, numbers was 596 with the optimal and the 496 in the non-optimal. So about, this comes out the same. Optimal will be about 50-55%. This one is about 55%. I was our chip was 48%. So basically, if you have optimal data, good results, then 496, 9.1% event rate, and if you did not have optimal imaging, it became 11.7%. So that's a difference. And remember, Renovate Complex has 75% IVUS, 25% OCT. So just to say, doing the imaging alone is not enough. To get the best result, you have to have optimal criteria. And this is, they have put it together in this graph and showing that all the important point. Now, so therefore, intravascular imaging to guide PCI. So now we got two of them. So now we are Renovate Complex PCI, intravascular imaging guided bifurcation PCI, both of them emphasizing that methodical intravascular imaging will improve your outcome. So just doing the IVUS alone is not enough. And they said you had to change. You have to change your strategy based on the imaging. So one, you do imaging. Secondly, change your strategy with the imaging. Now, in both the trials, the IVUS chip and optimum, the change of the strategy after the imaging happened only in 25-30% of cases. So a small number. So very important to say, and these trials have 50 to 70% change. So key is, one, you get. And actually the editorial with Greg Stone is our international fellow, Gaurav Arora, and came out very nicely to just say that if you do good imaging, it will be beneficial. So therefore, basically now question comes that what you do, how do you put it together? And this is our own data, the interpretation difference in the inclusion criteria. So how do I explain this disparate contradictory finding of the randomized trial? 2 plus, 2 negative. One is because differences could be inclusion criteria, that complex bifurcation, calcification, long lesions. Maybe there is more atheroma in the patients where the trial was negative, and we know almost more than 50% the stent landed in more than 50% lesion at the corners. Then second is the experience of the operator, and it has been said that regional and global differences, particularly in the Europe and UK and maybe America, they were not that compared to your East Asia and Japan and China. All those have much I was imaging experience because they have been using quite a bit and interpreting that. Then strict adherence to intravascular imaging performance, implication of set algorithm. So key, just doing it is not enough. You have to do it correctly. And also, I would say in last 2-3 years, there is improved stent design, techniques, and better post PCI depth and optimal medical therapy. Classical, giving a PCSK9. We know every trial, irrespective of the lesions you have, 1 to 3 vessel, PCSK9 decrease the event rate further. Lot of people have used colchicine, although one of the trial was negative in MI. But just to say that differences in could be because of the above said. So basically, key is just doing our intravascular imaging for the sake of doing it. It does not count. It's not enough. And therefore, you have to do it appropriately. Now, so what do you mean? What can we do now as a PCI operator? Because many people were happy, just like myself, that when the first 2 trials were negative, he said, well, at least now we don't have a pressure of doing intravascular imaging in every case. So high volume, let me put it together. And this is again, everyone, is my own interpretation, and put this data together, that high volume experienced PCI operator, there are data to show that less than 5 years or more than 5 years, imaging really makes a difference in the outcome in the less than 5 years of the practitioner. More than 5 years, there is still a benefit, but diminished. So younger the people, less volume they are, there is a big benefit of imaging. So let's go to high volume experienced PCI operator. Those were the the operators for both IVUS chip and the optimal trial. So key is PCI perform guided by angiography only. And what are the results? Optimal stent optimization. Angiographically, sometimes you can use stent boost, and reasonable long-term outcome. Now, what we learned over the years, that PCI perform guided by intravascular imaging, and of course angio is always there, so I made that in a small font, but basically it is done by PCI performance by the IVI intravascular imaging with angiography. And what we learned, it's an optimal stent optimization, an excellent long-term outcome, and lower MACE compared to the left side, which is the intravascular with the PCI done by angiography only. But this is one which we learned. Now, how do you interpret the trials which we have? Well, basically, I would say very simple here. What happened is, we learn over the IVUS, we'll know the OCT, that how to optimize stent, and now our eyeball, we decide to implement all the IVUS protocol learned, expertly guided by angio, and no IVUS need routinely. So what does that mean? That we learn by using imaging that how a stent should look. Should not be no dent. If there is a little doubt in the corner, we go back and put a stent even without imaging. So key is, this to me is the new era. So how do you put it together? It's very simple, that recalibration of your eye. What IVUS imaging has shown us, that recalibrate our eye or angio. So now, without even using imaging, we are getting a good results as shown by the 2 trials. Now, this is nothing new, because this has been documented in CCC conference right here, and by Anno, that coined the term IVUS. Instead of IVUS, IVUS. So Annu, you want to say, or there is a video there?
There's a video.
Yeah.
No, we say use your eyes. EYE was. Okay. Yeah.
So it is a
Intravascular, which is IVUS or EYE was. So why we call EYE is because we trained during our days, our IVUS was barely used. We used angiography, and everything was done using angiography. So
So just basically to say that now what there is, imaging made us better angiographer. So that is what I put it together. Samir, any question on that point?
Yeah, I have one observation and a prediction. So the observation is, I think your the incredible point coming out of your presentation is a point where you made that in your particular eyes, in after possibly 3-4 decades of doing complex PCI, you feel the biggest value of imaging is post-procedure. That to me is the brilliant statement which you made, which I think people can relate to. Second, looking into the future, I think you'll take a picture and an AI guided algorithm will tell you whether the lesion should have IVUS or not.
Beautiful, beautiful. All right, so let's go to a complete, maybe you want to show it now or your angiogram? And to show it later.
Okay, we can show. Let's see what you
let's
want
go to the pause here and let's show the angiogram now. So excellent job which has been done by Anu. Show it.
Okay, let's go back. I don't know, excellent job. Let's see. Anyway, we did the imaging. Show the imaging. Show the imaging first.
Yeah.
So we actually put a 3.5, a longer stent, 33.
Okay.
Come to the proximal LAD. Come to the left main bifurcation. And the proximal edge, still eccentric calcium in the osteo left main. But the stent is well expanded. This is the proximal LAD. The area is 6.1. It's more than 5.5, so optimal. And the distal left main area is the 9.1.
Beautiful.
This is more than 8. So stent expansion is great. Then distal edge, some gap, but there is no dissection, no malapposition. Distal edge looks good. Proximal edge is at the eccentric calcium, but no malapposition. So yeah.
Pot was what?
4.5.
4.5. Pot was done with a 4.5.
He says it's almost a 5.0 vessel, 5.5.
That's right.
We still went lower. I would have, I'll tell you one thing I would have did different, but anyway, you have to look at the angiogram. Now look at the angiogram.
Wow.
Pristine. Pristine.
Yeah. No, there's a proximal. Look at that little dissection there.
So
we've gone multiple views. Okay.
No, but more important, why did we not see it on the angio? I mean, IVUS.
Yeah.
No, it could be it is too. Look at it. This. Okay. Now look at this.
Yeah.
Then we did multiple views.
Yeah.
You see that?
Yeah.
Stable, no EKG changes, and I went back and did the IVUS again.
Okay.
Repeat the IVUS again. Show the final IVUS again.
Sure.
We did just that proximal to see if there's anything.
Anyway, intrastent it looks great. Now come to the connection. This is
right there. We don't see. It may be like you know what I'm outside.
This is again another limit. IVUS has a limitation because there's eccentric calcium nodule. We don't see the behind this calcified nodule because of the acoustic shadow. So actually, we are not sure behind this calcium. So.
No, I know behind the calcium, but it could be on the other side.
No. But other half is like no dissection based on this IVUS image. But angiographically, it's clear.
Big time.
Yeah.
Angiography is type B. If not C, because it looks like type B. So Anu, then what you did? Another stent?
I did not.
Huh?
Question is, do we stent or leave it?
Yeah. Go back to the angio. Oh my God.
The only thing is, if we had not used IVUS, I would have just gone with the 4.0.
Yeah.
You know, I would have done the 4.0 to the 8 millimeter.
Yeah.
But now with the 4.5, I don't know, we might have created this.
Yeah. I would have gone with the 4.0.
Dr. Kenny, point is not just the sizing, also we should consider the plaque morphology. So yeah, we discussed there is eccentric calcium in the proximal part of the left main. So sometimes too aggressive based on 1-to-1 ratio, it might cause that kind of dissection. So plaque morphology is also important for sizing.
Okay. Get a 408 Zions. Right? Go to caudal view.
What I meant is, even if you do 408 Zions, that dissection, which is adventitial deep down, may not change.
No, it will change.
I doubt it will change, but
no, remember there's not much plaque there. It's more of a dissection than plaque.
Yeah.
So it will go. It will expand.
No, I think it will not. But anyway, his PRU is good 184, but we will change. Even though his elderly is a good elderly, we'll change him to FE-end.
I thought one of the reasons also to stent it is it may have been induced by the guiding catheter and you don't want to take a chance of the vessel shutting down.
No, I don't think
Too
it's guiding.
critical.
In the sense
No,
that
but
we've
let's
been very
now
careful.
let's study angiogram a little more.
Okay, go back.
Yeah. Okay, what's happening there? Is
Uh,
any no attending?
Okay, here.
No, but let them check out. Yeah. See that?
This is not guiding. Guiding,
a
you see that?
proximal edge,
It is
I can tell
definitely
you.
Mhm.
proximal
Yeah.
edge of
Edge
the
with a
stent.
4.5 probably.
Right.
Yeah, this is
Exactly.
from the
Look
4.5.
at this. Yeah.
Now
Go
we're
to 12. Then
done.
not 8 or 12.
We put 8.
Okay.
And don't look at the circ, okay? There, please use dark goggles there. Look at the circ costume. I think that you can leave it out. Yeah.
You know, it is only you had taken the other projection. Otherwise, in this view, the left main looks just fine.
Yeah. Who is this patient? Who is this?
Okay. Now let us stent this. Okay, some dye. 8. 8 will be okay, you think? Or we need a 12?
Possibly
Okay,
a
come.
12, no?
Yeah, that's what I
Yeah.
A
thought.
little longer. Yeah.
Right?
I think so.
Yeah, yeah, 8.8. The
8.8.
ostium to the edge of 8.8. I was sure that. So
Now then if we do 12, it'll be sticking.
yes, maybe some overlap with the previous stance.
Overlap, but we won't cross the circ, right?
Mm.
The left main length is like 18, so long left main. So
Okay, get us a 12. I think we need 12. Some dye. Some dye. Yeah. See there. Yeah.
Give us a 4 or 12. There's a 4. There's a 4.5 12.
There is. You want to go 4, 5?
Is there a 4.5 12? 4.5. See if it's available. That's better. You don't have to push dilator. So right now, your really stent has to go to that adventitial level. Because deep medial dissection. Yeah. Good. Okay. Good. Yeah. Now try to understand where was the 4.5 balloon was. Let's see, maybe we can look into that.
No, that's not the thing. We did not even go.
Not, yeah.
No.
It did not.
Okay, go.
Yeah.
I think I have a cine. I have a
have it
cine.
here.
Yeah,
You're
there,
right here.
right there.
Yeah.
If you don't do that, then proximal edge is not covered. And we went only like 18, 16, 18. We were very cautious. Only question is 4. I think just believe your eyes. That's it. You know, Samir, what I was going to tell you for Nagarajan's thing about not using torquer. Like we say, use your eyes for everything. Use the tactile sensation and the fingers. So God-given sensory. So you got to train yourself to do all that. Keep training, and you'll get better at it.
Absolutely. You're going with the 4-5?
Yeah, 12 though.
12. Yeah. 1 second. Let's cut that.
Yeah.
1 second.
Only cranial. Now you have to confirm like this.
Yeah.
And I think this, this kind of
wonderful
bringing
use
the
of
shutters,
collimation.
again, only
Beautiful.
I train fellows who come here all the time using collimation, lung shield, proper camera positioning so that radiation exposure is minimized.
Good for the patient and the operators.
Yeah.
Some dye.
No, don't move.
Hey. Head down. Okay. Okay, now dye. Too much now sticking out.
Distal.
Yeah.
Okay, good.
Right.
Wait. Let me just take a scene, document it. Go. Oh, good. Okay.
Going up.
Get the IVUS again.
Yep.
But I didn't see it first time. There's no D.
No, that this
12,
is okay. That this stent is okay.
Okay.
I know we didn't see it first time.
1 second. Pull back few millimeter or go inside. Yeah.
I go
Good.
inside
That's it,
first.
that's it.
Yes.
10.
Okay. Okay, good. Down.
Let's take a picture first.
Mm. No, go up here because then balloon may not
Yeah.
go in again.
14.
Okay, down. That was an important point which Samir brought up. That could it was it a guide induced? Unlikely guide induced because in this view, see,
The
the dissection is
happens-
coming from the
distal
distal to
distal.
proximal.
yeah, distal to
Yeah.
proximal. So
Yeah. Let's take a picture now. Good.
Exactly. Perfect. Now this was
Okay,
the
let's
view which
let's
okay,
go
finish
to our
it.
yeah complete. While they are finishing the IVUS, let's go to our complete. Or you want to show IVUS now?
Let's quickly show the IVUS because it's just that stent, and then we can finish here and close. So 3 stents, okay.
So you, as we had learned from the IVUS initially, we are not going to touch the circumflex.
Yeah.
Yeah.
That was the lesson learned by imaging.
And more important, blood pressure and EKG. You can see that they're
Show
all
the
fine.
hemodynamics also,
Yeah,
please.
yeah. So that's a good sign. Okay.
Yeah,
Good.
check the
Image
image.
quickly.
Yeah.
Yep.
I didn't go to the
Okay.
distal edge
Yeah,
of the
start
stent.
to back.
Yeah.
Just a proximal part of the left main. Yeah, well expanded. Nice, 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 nice. Now come to the level of the aorta. It's covered the osteo left main.
Do you think we need to post there or
No.
leave it?
The
No.
area is like 15, well expanded.
15, well
Okay,
expanded.
okay,
That's why
okay.
I did. Okay, that's why I used 4.5 and show the hemodynamics also. Looks very good. Go back to the angiogram, hemodynamics, and we complete the presentation now. Beautiful. Look
Okay.
at that. No EKG
Outstanding.
changes.
So 1 millimeter of the strut is sticking out, which is ideal because we have to cover it. But then at the ostium, you see that it's fully opposed.
Yep.
Stent is fully opposed, right?
Yep.
Yeah.
Okay,
Okay.
good.
So let's go to our presentation now. Yeah, it's not working. Yeah, it's okay now, right? Good. So let me see the second one. A lot of controversy in ACC. 2 negative
Okay,
trials
ready?
of the imaging, and then another negative trial of the high risk PCI, which is a control trial of high risk coronary intervention with percutaneous left ventricular unloading, CHIP BCIS3. And this was the trial, again, simultaneous publication is from UK, and basically showed that patients who have LV dysfunction,
Ready?
decreased cardiac output, decreased perfusion, and go into shock, ischemic cascade. We know that's the cardiac shock. But many patients just ischemia, not infarction, and then you go block the vessel like this case, left main occlude, you will give rise to same ischemic cascade, and you can prevent it by putting the MCS, and particularly in this, they tried use the Impella device. So basically, target population was severe LV systolic dysfunction. They defined as 35% and low. Then extensive coronary disease. They call it a Jeopardy score of more than 8. And you know, Jeopardy is of the 12 segments of the coronary tree. That's they have been using in the BCIS trial, BCIS1, which is balloon pump. BCIS2 was the ischemic cardiomyopathy with the ischemia and still failed PCI compared to medical therapy. And now this was the complex planned PCI with a low ejection fraction, extensive CAD, randomize them to microaxial flow pump, which is Impella 148 versus standard of care. And these patients were followed for about 22 months, as you can see here. Now, what did they have individual design of the periprocedural myocardial injury, then hospitalization, spontaneous MI, stroke, death, and these are the hierarchical endpoint, and they use this, the definition of wins. So these are the various products in this. Impella was used as expected. There was total overall score was, as you can see here, is 12. Syntax score was 38. Truly very complex cases, with left main being in 72% of patient, and calcium modification was used in 81%. And CTO was in 27%. So really tough lesions. which were randomized into a Impala versus standard of care. What happened is that we found the major bleeding, which we expect higher with the Impala because of 14 French sheath versus 8 to 7 French sheath, 10.8, and then vascular complications same way, 16.9 in the Impala group versus 10.6. So very high major bleeding and vascular complication. And then the whole was that knowing that there may not be difference in the major endpoint, they have this called WINS situation. Now, what is the WINS? Each endpoint, they look into it, which technique is favored, whether it's a balloon pump on the Impala on the left side or standard of care on the right side, and whichever the higher the number is the basically win. So you can see here that every aspect, death from any cause, the disabling stroke, is spontaneous except spontaneous MI, which favored the Impala. Everything else and hospitalization was a little bit different, but everything else was more negative on the side of the Impala compared to a win for standard care. So what happened? Aggregate came 36.6 of your in the Impala group, 43.0 in the standard care. So basically means that if you take patients, which will be favored of the 100 cases, the 43% will be favored for the standard of care, 36 will be for the Impala, and 20.4 is the neutral. So that basically shows that the WINS point of view, this is where the event rate are high but no less difference, they use this criteria. But let's go to the real one. Real one was death from cardiovascular causes or any cause, 26.7 in the Impala group, 14.5 in the standard of care, and that's a odd ratio of 1.9, almost 2 in favor of standard of care. So therefore, Impala did not decrease the mortality, rather increased. Then is spontaneous MI, which we all learned. Good intervention, they have a lower spontaneous MI, like every trial which have been shown, 6.8 versus 12.4. But then they called also is the myocardial injury. They call it more than 20% of the baseline troponin increase or more than 5 times. Again, higher myocardial injury with the Impala compared to standard care because you did more cases and more complex interventions. So clearly that we learned that acute periprocedural MI is a little higher, and that is what's seen in this study also. So what does that mean? These are the numbers. Death from any cause, cardiovascular death, stroke, MI, hospitalization for cardiovascular, periprocedural myocardial injury, major bleeding, minor vascular complications, all majority of them were against the Impala or were favored the standard of care. And this basically came up with a conclusion among patients with severely impaired LV function undergoing complex PCI, elective left ventricular unloading with a microaxial pump did not reduce the risk of major adverse cardiac event at minimum of 12 months, although it was a little more 22 months and so. So this is a very shocker. We thought that these are the cases. We have shown them compared to against balloon pump in the Protect 1, Protect 2 trials, and of course 3 was just the registry. 4 is the one, to me, is the major trial of similar situation. That is complex PCI, ejection fraction was used to be 40, then became 30, and in the trial, as you know, BCI's 3 was 35. Impala CP versus control, 1200 per very large number of patients, and primary endpoint is composite rate of all-cause death, stroke, durable LVEF implant, or MI or cardiovascular hospitalization at 3 years, and minimum 1 year follow-up. So what happened is, in this case, I'm in the technical committee chairman. The trial completed, we did the last case. We did the first case and we did the last case on June 16th, 2025. So they had to wait data till end of June. Then they look into it. I spoke to Greg Stone after on the BCIS 3, so however we work out for the Protect 4, and we were the highest enroller here. So question is, what will the trial show? So he thinks that they'll get all the data together by September, October, will not be ready for AHA, but definitely will present in AHA next year. So BCS 3 negative this year, and we expect BCS, the ACC 2026. We think ACC 2027 could be favor of Impala, but we don't know. Nobody knows the data, and this is what will show by the trials. So that's where we are. So let's complete our take-home message that IVUS guided versus angio guided complex high-risk PCI MACE at 1.9 years, no difference. IVUS guided versus angio guided PCI of the left main. I put 2 thumbs down because not only no difference, there was a higher stroke rate, higher numerically higher stent thrombosis. So therefore I put 2 thumbs down compared to the IVUS chip trial in the 1 thumbs down. Second, IVUS guided, angio guided DK crush stenting, target vessel failure more at about 18 months and so, 2 thumbs up. And then lastly, imaging guided versus angio guided complex PCI outcome at 5 years, renovate complex, 3 thumbs up. And then lastly, a recent randomized trial of MCS device during elective PCI failed to show any benefit at 1 year, kind of 20 months and so, with the slightly higher mortality, periprocedural myocardial injury, and vascular complication compared to standard of care. These adverse findings are in contrast with the favorable outcome we seen with the MCS during cardiogenic shock, which is a dangerous shock. Therefore, until the results of the large PROTECT 4 trial of MCS during high-risk PCI are available, which will be ACC next year, Impella should only be used cautiously in selected patients with a low EF and hemodynamic instability. So just to say, Samir, this is the question. This is the answer to the question when people ask, would you use Impella in this case? And I too say, when the trial data comes, we have to be a little more cautious, and therefore we did not use the Impella in the current patient. So let's go to the quick 3 questions. Following are the true statement regarding the results of IVUS chip trial of high-risk complex PCI, except similar TVF, a similar death rate, similar TLR rate, similar stent thrombosis, and higher procedural time. Clearly the answer which is wrong, D. Because there was a lower stent thrombosis, despite all other points were negative, the stent thrombosis was was lower with the IVUS group, and there was a higher procedural time in the IVUS group. Second, optimal trial comparing IVUS guided versus angio guided PCI of the unprotected left main showed the following, except similar patient vessel oriented outcome, similar TLR, similar stroke rates, similar death rate, and numerically higher stent thrombosis in the IVUS group. Clearly, stroke rate was higher in the imaging group compared to the angio group. The third question, following are the true statement regarding the findings of the microflow perfusion chip Impella in the chip BCIS3 trial, except higher MACE rates with the microflow, higher bleeding rate, higher stroke rates, higher cardiac death rates, similar heart failure hospitalization, and basically showed the data is C. There was no higher stroke rate in Impella versus no Impella group. So with that note, I complete my presentation, and Anu has something to say. You have to say something.
No, any more more questions?
Yes, some observations. I mean, crystal clear when towards the beginning of the case you mentioned. I will answer the Impella later, loud and clear. And that really is the purpose of our being guided for the cases with the absolute clinical data. So outstanding. Anu, beautiful skills, great judgment. Excellent techniques, multiple wiring of challenging lesions, just a beautiful case. And I think the handling and placing the final stent was outstanding. Great guidance by imaging. Overall, outstanding cases. I've had many congratulations for your skills by viewers.
I think just the final slide. Remember, they asked the question, why fielder? So these are the various, fielder family wires. So we use fielder, the first one, most of the time. If you see why, even up to the tip, it's not tapered. Tip is also 0.14. But more important is that there is high hydrophilic coating over the polymer jacket. Because of that, the tip load is only 1. When you are actually accessing the side branch, this wire is preferred. I mean, I like this wire. But if someone wants to say that they would want to use fielder FC, that is okay, but tip load is slightly lower. We use fielder FC if we are doing retrograde and we are to surf the most of the septals. We do that. Of course, XT, XTA, they are all tapered. You see that? You see the tapered tips. So they are especially used for anti-grade, retrograde wiring. So that was a question about fielder. So yeah, I think this is a good slide to explain all that. And in the final what I need to say is that there's let's go back to the full slide. Come out. As a part of our training, and if you want to continue doing intervention, we got to train ourselves. So train your eyes and use your eyes. So eye is the key. And second important, where I keep telling all fellows that when they come with me and work with me, no torquer. We need to use our God-given sensation and train your fingers so you're able to wire and take care of any complex lesions. So train yourself, your eyes and your hands.
Anu, such a wonderful teacher you are. Samin, final comments. I think this illustrates what we did in the last 90 minutes. I'm quoting Dr. Suman Prasad Bihar. Excellent case and presentation. Congratulations to Mount Sinai Cath Lab team. Learned a lot.
Beautiful.
With these words, we conclude today, and we'll see you on May 19th for our next session.